Fine. Is it visible?
Yes, it is visible. I think all the participants can keep answering over the chat box.
Fine. So let's start the first question. Which among the following interventions has not shown to reduce BPD? HFNC, CPAP, volume targeted ventilation mode, and non-invasive positive pressure ventilation, not shown to reduce BPD. So fine, everybody is answering correctly. Can you tell us the reason? In one word, can you tell us the reason? So the answer here is HFNC, as everybody has rightly pointed out. So let's just quickly look at the evidence. So this is the evidence summary for the various respiratory modes in the prevention of BPD. So as you can see, this is from a meta-analysis, and this particular figure shows the forest plot. So compared to mechanical ventilation, CPAP has shown a reduction in death or BPD. See, it is favoring the intervention. Similarly, nasal intermittent positive pressure ventilation as a post-extubation mode compared to CPAP, also we have evidence as NIPPV as a primary mode. They have all shown a small reduction in BPD. Volume targeted mode, among all ventilation modes, volume targeted mode has shown reduction in BPD. So the reason is that volume targeted modes, because volume is stable, there is less fluctuation with carbon dioxide. There is less lung injury. That's how it protects. So HFNC has been shown to be non-inferior to CPAP, and it's not preferable as a primary mode. Therefore, among these respiratory strategies, HFNC has not been shown to reduce BPD. So now the second question is this particular case a BPD or not? So this is a preterm neonate at 26 weeks gestation at birth. Baby required surfactant, required ventilation for 7 days, then was on nasal CPAP for another week. From 30 weeks onwards, this baby is on room air. However, at 6 weeks of age, that is 36 weeks post-menstrual age, the baby acquired late onset sepsis, baby required intubation, developed VAP, pneumonia. So after 1 week on ventilation, the baby was extubated again and discharged home. So at 36 weeks, the respiratory support is mechanical ventilation with 40% FiO2. Chest X-ray shows atelectasis due to pneumonia. Is this case a BPD or not? So mostly 3, 4, 5, 6 answers, they are saying no. So why it is a no? Can anyone unmute and answer this question? Why it is not BPD? The baby is ventilated at 36 weeks corrected gestational age. Anyone?
Sarita ji, can you unmute the participants? Yeah, I think they are trying to answer in the chat.
Okay, sure. Okay. Nisha is telling baby should be continuously on oxygen support. So fine, let's just see how we define BPD. So this is an updated 2018 NICHD consensus classification. Previously, they said baby has to be continuously on 28 days oxygen, and then we reassess the baby at 36 weeks post-menstrual age. So at this 2018 consensus statement, they removed that 28-day requirement for oxygen. But they said that baby at 36 weeks, when we evaluate baby, it has to be a preterm baby born at less than 32 weeks gestation. The baby should be symptomatic with tachypnea, chest retraction. should have a chest X-ray finding which is consistent with BPD and require any one of the oxygen or respiratory support modalities. So they graded, rather than say mild, moderate, and severe, they graded the BPD as 1, 2, and 3. And then based on the FiO2 and the respiratory support, they classified. An interesting point here is that they gave a label of 3A. What is 3A? 3A is a baby who dies between 14 days and 36 weeks gestational age. These babies, because they die early, were previously not at all counted. They said that we should not miss these babies. So 3A would be a baby who could have died because of BPD, but at the same time, there should not be other causes for death. For example, the baby should not have died of intraventricular hemorrhage or necrotizing enterocolitis, etc. So this 3A addition was an important finding, and chest X-ray finding was mandatory. In 2019, Jensen et al., he modified that. He looked at whether the 2018 criteria holds good or not. What we are looking at is when the baby is 18 months of age or 24 months of age, do they still have respiratory problems? That is what they are looking at. So they are trying to see whether this classification of BPD, whether it helps us to predict later respiratory morbidity in the child. So they did a study based on that previous classification, and they said, just forget about the FiO2. It is only the mode of respiratory support that is more important, because that can predict the later respiratory morbidity. So grade 1, they classified grade 1 as any baby who is on nasal cannula less than 2 liters. Grade 2 is nasal cannula 2 liters or more, or any mode of non-invasive support. Grade 3 as invasive ventilation. They said this particular classification, mode is more important, not the FiO2. So that predicts respiratory morbidity in 80% of the babies. So when babies are in grade 1, the risk was 10% only, whereas when we are at grade 3, the risk is 77%. Now coming to that particular question, whether it is BPD or not, the child or the baby at 36 weeks required ventilatory support because of some other reason, and the chest X-ray was not consistent with BPD. It was showing pneumonia. The child could be extubated. So it was a temporary phenomenon. So you should have a preterm baby. Chest X-ray should be consistent with a diagnosis of BPD, and then you reassess at 36 weeks post-menstrual age. So that's the answer. So it's not a BPD because of the following reason. Another pattern whenever we discuss such extremely preterm babies is to look at the pattern of lung disease. So you have 3 patterns here. One is a low FiO2 pattern, but persistent disease. So these babies have a risk of CL, chronic lung disease, to the tune of 17%. Other baby is low FiO2, but later they have a progressive disease. Such babies have a risk of 50%. The other is an early progressive disease babies whose oxygen requirement is higher, and then they continue to increase. So at the end of 7 days, when you look at what respiratory support the baby is, you will be able to predict the pattern. So this particular slide is from the ELGAN studies, extremely low gestational age study. So now question 4, what is the X-ray finding in this baby with respect to lung disease? It is not about the ring which is shown in this particular figure, but please answer. What do you see with the lungs? 26 weeker who is still ventilated at 36 weeks post-menstrual age. So this baby was at 26 weeker at birth, but currently baby is 36 weeks post-menstrual age. Everybody please answer. There are only a handful of replies in this chat box. So bilateral diffuse haziness. So it is bilateral, right? The disease pattern is bilateral. And there is atelectasis. There is haziness. There is atelectasis. Some areas, some hyperinflation, but generally it is a bilateral diffuse, nearly atelectatic pattern. So it is not PIE as you people have replied. PIE is a finding which you see in extremely preterm babies early in the course of the disease, especially after surfactant treatment and continued mechanical ventilation. So there you will have more of a wavy pattern, the air in the interstitium. You can have either cystic pattern or you can have wavy pattern. So because this baby is a 36-weeker and the ring has been the PDA surgical ligation of the PDA or the clip that has been put. So this is a typical picture of the new BPD. In new BPD, you will find lung volumes can be maintained, but you will have diffuse atelectatic pattern as opposed to an old BPD where you will find diffuse fibrosis, cystic honeycombing, and areas of localized emphysema. So what is the main pathophysiology for the new BPD? Why the X-ray picture of new BPD is different from old BPD? Please type your answers. Why this X-ray picture of this new BPD is different from old BPD? Excellent. Many people are typing the correct answers. Yes, it is arrest of alveolarization, oversimplification of alveoli, right? So that is the correct answer. So as you can see in old BPD, you will have lot of focal fibrosis, scarring, emphysema would be there. When you look at the airways, there is inflammation, fibrosis, airway collapse. Whereas in new BPD, you have arrest of alveolarization, oversimplification, so fewer and larger alveoli. So that results in this different X-ray picture. Finally, the last question. If you have a 26-weeker on mechanical ventilation, the baby is currently 2 weeks, still ventilated and unable to be extubated. So somebody asks you, can we give dexamethasone to facilitate extubation of this baby and to prevent BPD? You have two answers. Yes, we should give because DEXA decreases the BPD risk, facilitates extubation. Therefore, we should give in this case. Their other argument is dexamethasone can result in cerebral palsy later. So it should be avoided in this case.
Dr. Sindhu, I think Ashish sir has joined. So okay,
Fine.
this is the last question, isn't
Yes,
it?
yes.
So
Yeah,
we can
this
probably
is the
wind up over 30,
Yeah.
40 seconds and then we can start with the second
Sure.
case.
Yeah.
I know it's a very controversial question.
Yeah. True, as you said, we have varying answers. 1 and 2. Some people are writing rule out other causes and then give dexamethasone. So late giving dexamethasone or any postnatal steroid after 7 days is called as late therapy. The earliest evidence came from the DART regimen. It showed that we could, with this particular dexamethasone, 0.89 milligram per kg, they could easily facilitate extubation. So we have evidence in the form of a Cochrane review, which included more than 21 studies. All had used dexamethasone except one. They showed that there was a lower incidence of BPD and that of combined outcome of death or BPD at 36 weeks was also reduced. Dexalate, Dexa decreased the facilitated extubation of these babies. And compared to early DEXA, it did not result in other complications like gastric hemorrhage. So always the question remind was whether it can cause CP. So cerebral palsy was associated with a higher dosage of dexamethasone. So the meta-regressional analysis shows that we have to weigh the benefits and harms. So when your risk of BPD in an index case exceeds 40 to 50%, BPD itself is a contributor for cerebral palsy. It can increase the risk of CP by 2.5 times. So when the index case risk of BPD is more than 40 to 60%, you can go ahead and give. So here you see 40% to 60%. So it favors corticosteroids. Whereas in the index case, if the risk is less than 40%, then you can wait and watch. So there are many risk assessment calculators, and from your own experience, we can decide. So in this particular case, 26-weeker, baby already intubated for more than 2 weeks. So risk of BPD is high. So we can think about giving postnatal dexamethasone. Thank you, Aparna. This is my last slide.